Good afternoon, colleagues, and thank you for joining us. I am Dr. Shanti Singh Anthony, Knowledge Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS PANCAP, based at the PANCAP Coordinating Unit in Georgetown, Guyana. Let me extend a warm welcome to you on behalf of PANCAP's Director, Mr. Derek Springer, and thank you in advance for joining us. This webinar is a collaborative effort between PANCAP and the Pan American Health Organization. Today, we will follow up from our previous webinar and continue to share updates from the recently concluded 10th International AIDS Society Conference on HIV Science in Mexico. At this point, I'd like to share a few housekeeping notes with you. Firstly, your mics are muted, and so if you have any questions, I ask that you type these in as the webinar progresses. We will take your questions after the presentation. Secondly, we're recording this webinar and will share the recording on PANCAP website for the benefit of the wider PANCAP partnership. And finally, you will receive in your emails a post-webinar evaluation. I encourage you to complete and share your thoughts and impressions. This will be useful for us to enhance future webinar experiences. Again, this webinar is an update from the International AIDS Conference on HIV Science in Mexico City. Our presenter this afternoon is Dr. Giovanni Ravasi, who is no stranger to us in the region. He's a medical doctor specialized in infectious diseases and public health with experience in HIV and STI clinical management, training and mentoring, surveillance and research, and technical cooperation on HIV prevention, care, and treatment policy development, implementation, monitoring, and evaluation. Since 2008, Dr. Ravasi has worked with the Pan American Health Organization as the Regional Advisor for HIV drug resistance, prevention, and surveillance, and since 2014 for HIV and sexually transmitted infections, care and treatment, based at PAHO's headquarters in Washington, D.C. He's recently attended the International AIDS Society on HIV Science Conference in Mexico City and will be presenting to us today on WHO recommendations on the use of Dolutegravir and other ARVs in adults and adolescents living with HIV. I now hand you over to Dr. Ravasi.
Thank you, Shanti. And let me just take a minute to share my screen. Okay. Can you confirm if you're
Yes. Yes.
The small or the big?
The big and the small.
Let's see if I can. Okay, I think now it's only the big one.
Yes, it is good.
Okay, great. And sorry for taking a few seconds to set this up. So thanks again, Shanti, and I think this is a great collaboration that we're having to disseminate up-to-date information on new evidence and new international recommendations to programs, providers, and other stakeholders from civil society around HIV care and treatment. And today's topic is specifically around the use of dolutegravir and other antiretrovirals in adults and adolescents with HIV, based on new WHO guidelines that have been launched and presented at the recent International AIDS Society conference in Mexico City. So I will quickly go through some overall information on the context and the evolution of WHO recommendations, focusing on first and second line in adults and adolescents, including aspects of use of dolutegravir in women of childbearing potential. Especially in the last couple of years, there has been a lot of new information, and that's why WHO has been updating regularly with interim guidelines on the use of antiretrovirals. And just a reminder, a follow-up next webinar will specifically focus on the use of antiretrovirals in children and the new recommendations on HIV treatment in children. So certainly the increase in the number of people on treatment is impressive at the global level, and the most recent figure is that 62% of estimated people living with HIV worldwide have access to treatment. And as you can see, the line, the trend of the line of number of people on treatment is sort of aligned with the expected 2020 target to meet the fast track target of 90% of people diagnosed with HIV on antiretroviral treatment. So I think it's also a good news that up to 127 countries worldwide have adopted the treat all policy, and it's about 85% of countries in the region of Latin America and the Caribbean that have updated their guidelines, and we know that remaining countries are in the process of doing so and implementing this policy. And almost an equal number of countries have already updated their policies and started operationalizing the transition to dolutegravir-based preferred regimens. An important aspect of the context is also the expansion of implementation of HIV drug resistance surveillance, specifically looking at the pretreatment drug resistance. And you can see there's many countries that have completed or have ongoing studies in Latin America and the Caribbean. And this is the specific situation in the Caribbean. Cuba, Jamaica, the OECS, and Suriname have completed their nationally representative surveys. Haiti and Barbados ongoing, and other countries are planning, but there's still few countries from which we have no information. At the global level, what has been observed is that in many countries, the pretreatment drug resistance to non-nucleoside reverse transcriptase inhibitors, which is the or used to be the preferred class for first-line treatment, has exceeded 10% of people initiating first-line. And that's a concerning finding, especially considering that this class was, at the time of implementation of these surveys, recommended as the preferred first-line. As you can see, definitely the resistance to NNRTIs, nevirapine and efavirenz, is way above other classes. And again, this is an important consideration, and one of the reasons why WHO has started since 2017 to recommend moving to non-nucleoside based first-line regimens, especially in countries with evidence of more than 10% of resistance. And another important finding is that in general, the pretreatment drug resistance to NNRTIs has been observed higher in women compared to men. And there's still a lot to investigate and understand about this finding, but it is possible that previous exposure to PMTCT regimens before the adoption of the B+ approach might be the reason for some of these results. And another important finding is that people that interrupt an NNRTI regimen and restart have significantly higher pretreatment drug resistance compared to naive persons, and that's why this is another population that should be prioritized when planning transition to dolutegravir-based regimens. About 3 times higher in ART reinitiators with prior exposures compared to naive. So that's why since 2018, WHO changed the recommendation for first-line regimen to a dolutegravir-based regimen with a backbone of nucleoside reverse transcriptase inhibitors for adults and adolescents, and also women and adolescent girls of childbearing potential. But in this case, with a very low certainty of evidence because of the concerning finding of association between dolutegravir and neural tube defects that I'm going to present shortly. So before at the beginning of 2018, the information that was available about the use of dolutegravir in pregnant women was quite reassuring. From Botswana, from the CEPAMO study, there was no increased signal of congenital abnormalities, as well as any adverse birth outcomes or severe birth outcomes in pregnant women exposed to dolutegravir compared to efavirenz. So this was quite reassuring for WHO to include dolutegravir in the new guidelines. Nevertheless, in May of 2018, an unplanned preliminary analysis of data from the same CEPAMO study in Botswana revealed that the incidence of neural tube defects in women exposed to dolutegravir at the time of conception compared to other antiretrovirals and compared to efavirenz was significantly higher, 0.94% compared to 0.12 in case of any ARVs, or 0.05 in case of when compared to efavirenz. So this, of course, this finding generated a safety signal from WHO and other international regulatory agencies and bilateral and multilateral partners supporting ART programs. And in the 2018 guidelines, a note of caution about the use of dolutegravir was included, saying that DTG at the time of conception may be associated with neural tube defect risk among infants, that DTG appears to be safe when started during pregnancy after a period of risk initially defined as 8 weeks and subsequently as the whole of the first trimester. And adolescent girls and women of childbearing potential who do not want to become pregnant and may receive DTG-based regimens with consistent contraception. And a efavirenz-based regimen is certainly safe and effective, but countries should also consider the other information, like, for example, the prevalence of HIV drug resistance to N and RTIs, which, as we have seen, it has exceeded 10% in many countries and may affect the effectiveness of efavirenz-based regimens in this population. So it's important to do a balance of benefits and risk. And since last year, also because of a strong and vocal intervention of civil society, programs have been encouraged to adopt a woman-centered approach in the decision-making about antiretroviral treatment and the use of dolutegravir, and not posing barriers of access for women of childbearing age, but rather adopt a human rights-based approach to the best possible treatment. So this is an assessment of DTG policies, and so countries have been either adopting policies of no DTG-based regimens for women of childbearing potential, or women of childbearing potential can access DTG if on contraception, and other countries have introduced the use of DTG based on an informed choice. So these are some of the examples of implementation regarding the signal and the note of caution for the use of DTG in women of childbearing potential. And of course, this is before the new WHO guidelines have been released in Mexico. So in the meantime, WHO has updated a revision of scientific evidence on the use of DTG in first line and second line, as well as the use of TAF as an alternative to tenofovir in combination with 3TC for the treatment of HIV. So regarding the use of dolutegravir compared to efavirenz 600, the finding of the new systematic review and network meta-analysis showed that DTG continues to be better in most efficacy outcomes, except a comparable mortality rate. And regarding the safety and tolerability, dolutegravir has less neuropsychiatric adverse events, and overall a better genetic barrier to the development of drug resistance, although there are some side effects related to sleep disorders, body weight gain, and the possible association with neural tube defects that are comparable, or efavirenz could be probably better than dolutegravir. Another comparison was made between efavirenz 400 and efavirenz 600, and regarding treatment discontinuation, treatment-related adverse events, and treatment discontinuation related to adverse events, efavirenz 400 has shown better outcomes compared to efavirenz 600, while all the other efficacy and safety outcomes analyzed were comparable. So when looking at new antiretrovirals included in the guidelines, DTG is still the one that has the better characteristics as far as efficacy and safety, simplification, opportunities, harmonization across populations, and costs, with, of course, some level of evidence about its use in children and women of childbearing age that are still to be completed. So the two main recommendations in the new guidelines just released in July are that dolutegravir in combination with a nucleoside reverse transcripted inhibitor backbone is recommended as the preferred first-line regimen for people living with HIV initiating ART, adult and adolescents. And this is a strong recommendation with a moderate certainty of evidence and includes children, women of childbearing age and pregnant women. And the second, so it from a conditional recommendation with a low certainty of evidence is now a strong recommendation with a moderate certainty of evidence. And the second new recommendation is that efavirenz at low dose, efavirenz 400, in combination with an NRTI backbone is now recommended as the alternative first-line regimen for adults and adolescents with HIV initiating ART. So this is how the table of preferred alternative and special circumstances regimens look like. Tenofovir 3TC or FTC and dolutegravir is the preferred first-line regimen, being the efavirenz 400 one the preferred the alternative first-line regimen. Of course, the note on the use of DTG is maintained. Effective contraception should always be offered to adult women and adolescent girls of childbearing age or potential. But dolutegravir can be prescribed for adult women and adolescent girls of childbearing age or potential who wish to become pregnant and who are not otherwise using or accessing consistent and effective contraception if they have been fully informed of the potential increase in the risk of neural tube defects at conception and until the end of the first trimester. So a note on this aspect is maintained, but the recommendation of the use of DTG in adult women and adolescent girls of childbearing age is strong with a moderate quality of evidence. And we will look at the new information presented at IAS shortly. And the other important aspect is that if women are identified as pregnant after the first trimester, DTG should be continued or could be initiated for the duration of pregnancy. As you can see on the side of the special circumstances, efavirenz 600 is maintained as an option, or as well as protease inhibitors, but there are other options for dolutegravir based regimens with abacavir 3TC or with TAF 3TC or FTC, especially for cases of persons with bone or kidney diseases that have contraindication for the use of tenofovir. So this is another important inclusion in the new guidelines, the TAF XTC dolutegravir. So why the strength of the recommendation and the quality of evidence was changed? Because a new analysis of the study from the CEPAMO cohort in Botswana actually revealed a major reduction in the rate, in the incidence of neural tube defect from 0.94 to 0.3, bringing down the estimated incidence of neural tube defects to a level that, although higher than other antiretrovirals, is very, very low, with 2 excess cases of neural tube defects every 1,000 exposed children or women, pregnant women with exposure to DTG at conception compared to other antiretrovirals. The analysis of other adverse birth outcomes and severe birth outcomes with DTG compared to efavirenz also showed that there is no significant difference between dolutegravir and efavirenz for other specific adverse birth outcomes. Besides these new evidence from the CEPAMO study, and again, it's important to consider that this finding is from one cohort, from one country, and also in a context of non-fortification of food with folic acid. There have been another important evidence that was used for decision making by WHO and the guideline development group was modeling of impact of use of dolutegravir versus efavirenz-based regimens in women and this modeling was applied in South Africa and sub-Saharan Africa. The SEPAC and the HIV synthesis are the 2 models that have been recently published. So this is a summary of the criteria and the parameters that were included in the model, and basically the comparison was between efavirenz-based regimens, DTG-based regimens, and DTG and use of DTG only with long-acting contraception. And the aim of these modeling was to estimate the impact of the use of different regimens in women of childbearing potential beyond neural tube defects, but also looking at vital suppression, maternal death, sexual transmission, mother-to-child transmission, and survival. So in the SEPAC modeling, what was observed was that the use of efavirenz, even though associated with less cases of neural tube defects, was actually associated with an increase in the number of deaths of women with HIV, as well of sexual transmission as to their partners, and cases of mother-to-child transmission, basically because of the reduced efficacy of efavirenz in terms of vital suppression, especially in the context of pretreatment drug resistance above 10%. So this kind of gives a broader look at population-based outcomes beyond neural tube defects, but also looking at other possible outcomes of efficacy of dolutegravir-based regimens compared to efavirenz. And similar findings were observed in the HIV synthesis with increased deaths among women, sexual transmissions, cases of MTCT, although this is over a period of 20 years compared to a period of 5 years in the previous modeling. So basically the conclusion from the two models, and you may find more details in the articles that are available online, that women of childbearing potential initiating ART with efavirenz rather than dolutegravir to avoid neural tube defects would likely lead from a population-based perspective to other negative impacts, such as reduced response to treatment, survival, sexual transmissions, and transmission to their children. And as I also mentioned previously, the voice of the community has been quite vocal from the international community of women living with HIV, not to restrict access to dolutegravir, considering that the benefits may outweigh the potential risk, but rather to adopt a human rights approach to access and the woman-centered approach. So the safety and efficacy of dolutegravir was also compared to protease inhibitors, in particular lopinavir, ritonavir, for the use in second line. And it's this systematic review and network meta-analysis showed that vital suppression is higher with dolutegravir in second line compared to lopinavir, and also treatment emergent adverse events and treatment discontinuation due to adverse events better with dolutegravir compared to lopinavir, in this case is used in second line after a previous failure of an NNRTI-based regimen. So the recommendation on the use of DTG in combination with an optimized NRTI backbone as preferred second line was confirmed. And again, for countries considering the current use of non-nucleoside reverse transcriptase inhibitors based regimens for first line, DTG would be the preferred option for second line with a treatment backbone optimization. So using AZT, 3TC in case of failure of tenofovir, 3TC or FTC based regimens, and the use of tenofovir plus lamivudine or FTC in case of a failure of an AZT 3TC based regimen. And alternative second line regimens would be based on protease inhibitors, lopinavir, ritonavir, atazanavir, ritonavir, and darunavir, ritonavir. Of course, if in case of a treatment failure of a dolutegravir-based regimen, then the preferred second-line regimen would be with atazanavir or lopinavir as preferred second line, with darunavir as an alternative second-line regimen. One finding that has been observed in many cohorts and that it's still under investigation is an increase in body weight in people living with HIV using dolutegravir-based regimens, with a significantly higher weight gain compared to other regimens, although it is important to notice that the increase in weight is higher in people using TAF XTC dolutegravir regimens compared to others. But this is it's not a barrier to the use of dolutegravir, but certainly an important warning for providers to advise people initiating treatment with dolutegravir about dietary habits and exercise, and the importance of quit smoking and controlling hypertension and other risk of cardiovascular diseases. Also, there are some important drug-drug interactions with the use of dolutegravir, especially anticonvulsant agents. In the case of carbamazepine, DTG can be used twice daily or using other anticonvulsant agents. And in persons with TB, HIV co-infection, rifampicin can be used, but DTG needs to be used twice a day. So this is in summary what has changed compared from 2018 to 2019 with the use of DTG in first line for all adults and adolescents, including women of childbearing potential, as a strong recommendation with a moderate certainty of evidence compared to a previous very low certainty of evidence for women, and with a strong focus on a woman-centered approach. The alternative second line now is efavirenz 400 based regimen with efavirenz 600 used in special situations. And the use of DTG as a second line in case of failure of a NNRTI based first line regimen with PIs as preferred option in case of DTG failure in first line. At the same time as these new recommendations, WHO also released a new update implementation tool on providing contraceptive services in the context of HIV treatment programs, and focusing on access to integrated sexual and reproductive health services with HIV comprehensive care, and ensuring the whole range of contraceptive options with a life course approach, and especially for women and adolescent girls receiving ART and DTG. One final information, all these new guidelines are also available as an app that can be downloaded on your smartphones and tablets. And of course, all the documents are available on the WHO website. So thank you very much, and we can certainly have question and answers.
So thank you very much, Dr. Giovanni Ravasi. I encourage participants to type your questions in, we'll take them. In the meanwhile, Dr. Ravasi, I have a question for you here. So I've observed that it's the OECS and I think 2 other Caribbean countries that have done their pre-treatment HIV surveillance study, which I think it's also not bad compared to not having any data. But what I wanted to get from you is, do you think that if we're to take what has been done so far with the OECS, and I think there were 2 other countries, do you think that there is enough data for us to be able to say or to guide the Caribbean? So yes, Cuba, Jamaica, OECS, and Suriname. Do you think that from those studies that have been done, that there is enough evidence that could guide the Caribbean to say this is what we think pre-treatment HIV surveillance drug resistance looks like in the Caribbean? And building on that question, I noted on the graph where you did sort of a global comparison that large programs like Vietnam and Myanmar had below 10%. I think they were like 5 to 6%. But even closer to home, Colombia and Brazil had lower than 10%. And I'm wondering what lessons can we learn from those countries so as to keep our first line intact and try not to move beyond that 10% threshold.
Sure, I can try to answer this question and make some comments. Certainly, it's encouraging to see that HIV drug resistance surveillance is being scaled up. And it should be an ongoing process and not just occasional surveys. But of the countries that have completed surveys, only Cuba and Suriname have finalized the analysis and released the results. So in the case of Cuba, the prevalence was quite high, was even about around 20%, and the decision was immediate to move to dolutegravir transition. In the case of Suriname, it was still below 10%, but it was also a 2015 sampling, so it would actually be now time for a new one. The dolutegravir transition was not operationalized immediately, but I think Suriname is now considering moving to dolutegravir, not really because of a concern in resistance, but because dolutegravir has better outcomes, as we have seen from the systematic review and network meta-analysis in terms of continuation on treatment, vital suppression, CD4 recovery, and a more favorable safety profile, although with some specific issues that need to be considered. So I think while at the beginning the 10% threshold was used by WHO to recommend an accelerated response to transition from NRTI preferred first-line regimens, now it's certainly a factor of acceleration, but even countries like Brazil with a less than 10%, long before, even before the WHO recommendation on dolutegravir, the Ministry of Health decided to move to dolutegravir again because of the evidence of having better outcomes at a larger population level. So I think HIV drug resistance surveillance is still important because we now also need to monitor the possible emergence of integrase inhibitors resistance, although in general dolutegravir has a very high genetic barrier. So this has to be an ongoing practice. And countries should start planning their transition to dolutegravir-based regimens regardless of the 10% threshold, but certainly those countries that have detected more than 10% should really accelerate the transition. The only specific situation where there might be some barrier to the transition is in the case of intellectual property barriers, and I'm thinking about the patent protection for dolutegravir, which is a barrier to access low-cost generics. So in these cases, of course, a tailored approach should be discussed.
All right. Thank you so much, Dr. Ravasi. I wanted to make a comment followed by a question. I think it's no surprise that pre-treatment drug resistance to NNRTI is higher in women compared to men, but I am feeling from your presentation that it's almost like a double-edged sword with your neural tube defects of 0.94% initially, but then that's subsequently decreasing vis-a-vis your pre-treatment resistance to NNRTI. And I think the recommendation and the point that you made in us understanding how to balance the risk and the benefits is really important as we think through management. My question is on, you spoke a lot about TAF. And my question is on TAF. So how accessible is TAF to us in terms of affordability, availability? Is there a generic form? Is it readily available? How accessible is TAF? And then my second question is more of a programmatic one. You would know that the majority of our patients in the Caribbean are on a triplet as a first line. And I saw from the slide that WHO is recommending that if there is a failure to a triplet, which is what we have most of our patients on, that then you move to a dolutegravir-based second-line regimen. I know that there has been some discussions around even making the switch before failure from a triplet to dolutegravir as the preferred first line. What's your thought on that?
Okay, so let's say quickly regarding TAF is still is introduced as an option in special circumstances, because there are still gaps in knowledge about the use of TAF in different populations, and so there's not enough evidence to support its use more broadly. But certainly, in case of first-line treatment in persons with a history of bone disease or kidney disease, it's an option that can be considered. There are no WHO pre-qualified products at the moment, but there is a fixed dose combination of TAF, FTC, and dolutegravir that is, if I'm not wrong, tentatively approved by FDA and included in the PEPFAR list of antiretrovirals. So it can now be, I think most countries in the region are using many countries are using the PAHO Strategic Fund as a regional mechanism for procurement. The TAF based combination with dolutegravir is not yet included, but with the release of these new guidelines and the fact that a combination exists in the PEPFAR list, then this makes it accessible. But we don't have yet a reference price to share.
Okay. Okay.
And regarding, so your other question was about what to do with physician. So DTG can be now used as a second line in case of treatment failure of an efavirenz or nevirapine-based regimen. But considering the side effect profile and the lower genetic barrier of efavirenz and especially nevirapine, a transition even before a treatment failure can be considered, has been considered in many countries, especially in persons with significant side effects, especially psychiatric side effects related to efavirenz. So I think the transition of first line before failure is certainly encouraged in persons of nevirapine, is encouraged in persons on efavirenz, especially if they have side effects. Of course, it's important to always check the vital suppression, because a decision needs to be taken regarding the backbone. So if vital load is suppressed, the same backbone can be maintained. It's just a matter of switching to from efavirenz to dolutegravir or using TLD. But if a detectable vital load is if the vital load is detectable, then the switch should be switch to a DTG-based second line with an optimized switch of the NRTI backbone. So I think it sounds complicated, but actually it can be easily planned through forecasting if few specific transition criteria are defined at the country level.
Okay, great. Thank you so much, Dr. Ravasi. At this point, I hope that you can see the poll, but it's saying, based on the poll, the results are showing that 75% of participants do not use Dolutegravir. In their programs, 25% are using it. I think we've gotten a good breadth and depth of evidence that really supports the use of Dolutegravir in our programs. And so I encourage each and every one of us to continue to engage with the evidence and work towards enhancing our treatment program so that we can continue to provide the best treatment and care for people living with HIV. This brings us now to the end of our webinar. I wish to extend a really big thank you to our presenter, Dr. Giovanni Ravasi, on behalf of myself, PANCAP, and all the participants present here. It's always a pleasure working with you, Dr. Ravasi. Thanks again. It was really very insightful, like I said, really sound and good evidence in support of the use of Dolutegravir. Thanks to you colleagues for joining us and participating in this webinar. I trust that you're all better equipped to work, like I said, towards strengthening and enhancing our treatment program so that we can continue to provide the highest quality of care to people living with HIV. As Dr. Ravasi said when he started, the next webinar will be focused on the use of antiretroviral therapy in children, and so I encourage you to join that one as well. The announcement will be sent out shortly. Finally, as a reminder, the webinar was recorded and this will be shared on PANCAP website, and I encourage you to complete the post-webinar evaluation that you will receive in your email shortly. Thank you very much, colleagues, and have a good afternoon.